Hello, my name is Rakesh Jain. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 3 of this 3-part CMEO Snack series on overcoming barriers to the use of long-acting injectables in schizophrenia management, because every patient deserves recovery. Today's episode is titled Addressing Racial Disparities in Patients with Schizophrenia, Making the Commitment to Do Better. This CMEO Snack series is supported by an educational grant from Alchemies and is brought to you by CME Outfitters, an award-winning, accredited provider of continuing education for clinicians worldwide. Again, my name is Rakesh Jain, and I'm a clinical professor in the Department of Psychiatry at Texas Tech University School of Medicine in Permian Basin, Midland, Texas. I'm pleased to be joined today by Dr. Oladuni Oluwoye, Assistant Professor at the Elson S. Floyd College of Medicine, Washington State University, and Co-Director, Washington State Center of Excellence in Early Psychosis in Spokane, Washington. Welcome, Duni.
Thank you, Rakesh. I'm really excited to be discussing this today, and I hope that everybody else kind of takes away from what we have to talk about today.
Yes, I intend to take away a lot of tips from you, so I'm very glad to be joined by you. You really do have a reputation for excellence in this field. And to frame today's episode, let's start by reviewing our learning objective, which is to implement strategies to address racial disparities in the diagnosis and management of schizophrenia by removing implicit bias, establishing trust, providing education, and engaging in shared decision-making. So, Duni, healthcare disparities are not something new. Fortunately, we are now having more open conversations about these disparities, how they impact patient outcomes, and what we can do to turn the tide. To start that discussion, can you perhaps give us a little background on racial variations and the prevalence of mental illnesses?
Yeah, absolutely. So roughly 42% of the U.S. population are people of color, right? And so what we see is that there's a high prevalence rate of mental illness, which accounts for about 70% of that population of people of color. And so what this slide here kind of outlines is that it's relatively consistent across each racially and ethnically diverse groups. And it's not driven by one specific group, where we see, for example, African Americans make about roughly 13.4% of the US population, but of that population, about 16% of individuals report having a mental illness. And I think this just goes to speak about the problem that we kind of face in the United States in terms of the prevalence of mental illness, and as we'll kind of talk about a little bit further, even the use of services, where we tend to see these disparities widen even further.
So, Duni, these statistics are incredible and should give providers a higher index of suspicion for mental illnesses in these groups. This is particularly noteworthy given observations that have been noted regarding mental health, help-seeking behaviors in minorities. Can you share some of those observations?
Yeah. So when we talk about delays in seeking services, we're speaking specifically to pathways in care, which can be impacted by stigma within the immediate family, or it can be impacted by stigma that society has placed on mental health. And for racially and ethnically diverse groups, they are impacted by double stigma. And so delays in seeking services could also be due to a lack of services provided for monolingual families in the community. For instance, on this slide, we see that Spanish-speaking Latinx individuals are less likely to use mental health services. As a whole, racially and ethnically diverse groups are more likely to delay seeking mental health services and are less likely to remain engaged in services.
It is a challenge, Duni. Stigma and those help-seeking behaviors that you discussed have really a far-reaching impact, particularly as it pertains to mental health service usage. Here, I could perhaps ask you to discuss the racial variations that have been observed in that domain.
Yeah. So what we are looking at here is data collected from SANSA, which was reported in 2018. And you can visibly see that less than 11% of African Americans, Asian Americans, Latinx individuals, and Native Hawaiian Pacific Islanders received mental health services. And rates are even lower for being prescribed medication and the use of those medications. We do see that for American Indian, Alaska Native individuals, the rates are a little bit higher, but generally speaking, once in treatment, American Indian Alaska Natives actually do relatively well with remaining engaged in services.
Interesting. And Duni, besides being an adult clinician, I'm also a child and adolescent psychiatrist. And given the data that you just shared, it's not surprising how minority groups feel about the quality of healthcare they receive compared to their white counterparts. For example, let me invite you to look at this particular data set. The perceived racial disparities in mental health care even go all the way down to children. So 31% of white children with mental health problems receive mental health services. This is a perception. But on the other hand, only 13%, a very noticeably different percentage of children from diverse racial and ethnic backgrounds with mental health problems are perceived to receive mental health services. And on top of that, if I may encourage you to look at the left-hand side of this slide, white healthcare providers often do have belief systems that are worth thinking about. So 51% believe that their patients do not adhere to medical treatments as a result of cultural or linguistic barriers. And an even larger number, 56%, report having no form of cultural competency training. So as you can see, there are significant barriers and areas of potential rectification. So Duni, now that we have looked at some of that, we have discussed racial disparities in mental health in general. What have you learned about racial disparities specific to psychosis and psychotic disorders?
Yeah, this is an area that I specifically focus on, which is first episode psychosis in individuals diagnosed with a schizophrenia spectrum disorder. And so what we see, there's limited studies that kind of point to a higher incidence rate for first episode psychosis among racially and ethnically diverse groups compared to white individuals. While we also know this is actually not new, Black individuals are 5 times more likely to be diagnosed with a schizophrenia spectrum disorder, but they're also more likely to be misdiagnosed with that same disorder as well. As mentioned in the previous slides, racially and ethnically diverse communities and families experience more difficult pathways to care, which not only impacts the delay in services, but also engagement once they are in services. And recent literature, it's actually not recent literature, I think there's been more of a focus on it now, in that perceived discrimination and racism are associated with psychosis-like experiences and the risk of psychosis, especially among racially and ethnically diverse groups. And I think that this just points to the fact that we need to have more of a process and more of a focus on how discrimination and how racism impact the prevalence and the incidence of mental health disorders, and what that impact is on treatment outcomes too.
Duni, I gotta say, your data gives me great reason for pause. 5 times more likely to be diagnosed with schizophrenia if the only difference is you're Black compared to white, and double trouble. These individuals clearly have greater trouble accessing care. This is kind of a modern day tragedy, is it not?
Yeah, it is. It's really concerning when we think about trying to get individuals into treatment earlier. And when I mentioned the double stigma in some of the earlier slides, it really has an impact in just receiving services and what those outcomes kind of look like. And so if you're thinking about the experiences of individuals who are racially and ethnically diverse here in the United States and abroad, coupled with the experiences of trying to engage in services and trying to engage with providers, it's a dire situation that kind of needs to be addressed at multiple different levels, not just at the interpersonal and individual level, but at a systemic level and a community level also. building on what we have originally spoken about in terms of racially and ethnically diverse communities and the disparities that have been noted in the prevalence of mental health and the use of services, can you talk us through what are the risk factors associated with poor adherence to antipsychotic medications?
I'll be happy to, Dooney, and I have been a psychiatrist now for 32 years. And I must tell you, adherence challenges have dogged me from the first year of practice, and they continue to dog me. They really are challenges for our patients, and they could be broadly divided into 4 categories. The first could be patient-specific, so it could be challenges with insight, could be negative attitudes about the disease. It could be comorbid substance misuse, cognitive impairment. There could also be issues surrounding treatment, Dooney. So what if there's side effects the patient doesn't tolerate, or the medication's not very effective? And as you just alluded to, there are environmental and relationship issues that can impact adherence. For example, lack of family support, problematic therapeutic relationship, and then, of course, societal. This is a village approach, is it not? So it's not just the individual. Entire societies can impact how a patient is adherent to their medications or not. What is the stigma associated with it? And underlying all this, and this is what I really want to draw everyone's attention to, that race, ethnicity, gender, sexual orientation, socioeconomic states, etc., all influence these 4 buckets.
Absolutely. I wholeheartedly agree with that, especially when you think about individuals just don't live in one category and they're at an intersection of multiple different individual level factors. I think it's a really important point that you brought up in that they influence not just treatment adherence, but other outcomes as well, such as outcomes and engagement. And so I thank you for bringing up that point. So there are known obstacles to using long-acting injectables, which are a safer and a more effective tool in the management of schizophrenia. Can you discuss some of what those are with us?
I'll be happy to, and long-acting injectables have been a real boon to psychiatry, but there are obstacles. Dooney, I remember very fondly my very first rotation in psychiatry, going way back now. And it's important to remember back then, 30 plus years ago, and today, long-acting injectable medications often serve as the backbone to the optimized care of our patients who sadly suffer from schizophrenia. But there are obstacles. Let me have you reflect on this slide, and I'll make a few quick points. First of all, there is a significant anti-shot sentiment that often exists in all cultures, but it may be particularly challenging in patients of diverse backgrounds. So for example, less than 10% of patients actually get it. Psychiatrists often don't offer it in as many 2/3 of their patients, even knowing that this disorder really does deserve ongoing treatment, and non-adherence with oral medications is a problem. The challenges tend to be with refrigeration, storage, reconstitution, cost, overburden public agencies, frequency of injection, need for other concomitant medications, sometimes acquisition costs. All of those are true. But having said that, it is so important to remember that often long-acting injectables do serve as the backbone to optimized care. But to remember that race, ethnicity, gender, sexual orientation, socioeconomic background are all potential distractions, obstacles in optimizing the acceptance of LAIs by our patients with schizophrenia.
I agree with that. Like the work that I have done with families and clients, and especially as families serve as an advocate for a lot of clients a lot of the time, the first thing that they ask about is a long-acting injectable for their loved one, where they really have to advocate for themselves. And I think that speaks to the second bullet point here, and psychiatrists not offered that to a lot of their patients.
It does appear, doesn't it, that often the solutions to these problems may lie inside us. And I like that because I'm always looking for opportunities to improve. And that's why this conversation today is so wonderful. So, as providers, we all want what is best for our patients, and we work diligently towards achieving what should be patient centered treatment goals. But minority patients often feel that those goals are devoid of their input. So, why don't we do this? Let's learn from the very best teachers out there. Those best teachers tend to be our very patients. So let's listen as two individuals living with schizophrenia share their experiences.
I always notice I'm not taken seriously or very seriously like I should be with my symptoms compared to, I notice more specifically, people who are Caucasian seem to be taken way more seriously than me in situations and environments where I'm at a outpatient clinic or especially psychiatric hospital. But I do notice many times that I've been to the hospital, if I happen to get upset about how I am being treated, whether or not the situation is because of my race, I definitely seem to get the brunt of the worst of use of restraints, in my opinion, because of my race, because my anger towards how I've been treated in the past, and sometimes recently as well, seems to really get the brunt of it all. Being, restrained in a very aggressive, in my opinion, almost assaulting manner. It's really scary, and it has really caused me to be afraid of getting help because of that.
Yes, it was very hard for me to get the right medicine. I was prescribed some other medicine, which made me get worse. My symptoms get worse, and I had to be hospitalized twice again, Also, I didn't feel like I received the right treatment at the hospitals. As far as race, my symptoms wasn't of concern of some of the doctors that they didn't care for my symptoms.
Duni, that was hard to listen to, but important for us and all of our colleagues to listen to the direct testimonials from our patients about their perceptions of how they feel the system has let them down. And as we heard, that lack of therapeutic alliance, optimum therapeutic alliance, can absolutely lead to medication adherence challenges. And to really support my point, I brought this really important data set from Chang and colleagues that was published in 2019 that shows that, sure, duration of illness has an impact. Symptom severity has an impact on adherence. But I really would love for you and everybody to note what insight or absence thereof and therapeutic alliance in particular does to long-term adherence. And patients who report having better therapeutic alliances with their clinicians showed favorable medication adherence. And of course, the reverse is equally true. And this is true even after adjustments for factors that might have affected adherence have been made. What do you think, Duni? Have you seen this too? And was it also hard for you to hear these patients?
It was. I'm glad that we had the opportunity to listen to that. And on the other side, I'm glad that we were able to hear about their experiences. Although a lot of it seemed like it was negative experiences, I think sometimes that is needed to hear in order to make changes. And so I'm glad that we were able to kind of provide those client perspectives into this to kind of give a little bit of lived experience and firsthand experience from individuals with mental illness.
I agree with you. Sometimes feedback like that from the very people we serve, the very reason for our existence, is exactly what is necessary. And it moves us. It gives us an opportunity to make changes, which is the entire title of our presentation. And I believe you have some more audio clips for us to listen to.
Yeah. So many racially and ethnically diverse clients feel like there's a lack of treatment alliance with their providers, which limit their treatment options and overall care. So we have another clip to share about the experiences of racially and ethnically diverse clients and their experiences with shared decision making. So let's take a listen.
I'm always told this is the best option for you. Where the doctors get their information from based on them not knowing me well, especially if I go into a doctor for the first time or the first 2 or 3 times of seeing them, I don't know where they get their information that this is the best option for you. And a lot of times, more often than not, I'm not even able to have a discussion with my doctor. He or she just tends to kind of shut me down on my opinions about what I think is going on with me, what I think is best for me, and kind of just say, well, this is probably what's best for you. And for them to say that makes me angry because I feel like I'm not being listened to. I feel like I'm not being included in my treatment, kind of like I'm not even in the room. I do know that when I go into actually probably every mental health provider, initially they seem to have a judgment about me based on how I look and how I dress, that I must not be educated on knowing about medical information or medical knowledge, basic medical knowledge even, or even if I understand myself, which is very frustrating to have that judgment upon me.
For members in my online community who are people of color living with schizophrenia, I would say that most definitely in my interactions with them, talking to them, that options seem to be much more limited. It's as if the psychiatrist knows best. They typically have a bigger ego, I feel, and knows best and won't give the person many options, or there's a language barrier. And as far as like long-acting injectables, those I've found that haven't been very much so pushed as much as just medicate like pills have been. And I feel that yes, race does influence those discussions in the way that the person is not really listened to or can't be understood because of the lack of people who speak, or psychiatrists, counselors, or whatnot, who speak different languages, like Spanish specifically. There's a huge lack in the U.S.
I think that those 2 points that were brought up really highlights how far we have to go in terms of system level changes that need to be made, and the additional training in terms of cultural responsiveness among our providers. And so, yeah, it was a little hard listening to those two clips. But I think that, like I said before, it's important that we listen to these things and that we make changes.
I agree with you entirely. I think humbleness and humility are the two things I wanted to have more of as I listened to these patients, and to fully understand that just because I say so, that's not the key. It's shared decision making that I should do with all patients, but particularly patients who perhaps feel marginalized, as these two patients have talked about based on their previous experiences. So perhaps what I'm hearing them say, Dooney, very loud and clearly, is communication matters. The right kind of communication matters a great deal. And as we heard one of the patients say, with LAIs, it may matter even more so. So here's one data set where it shows that in this study of communication patterns in the offer of LAI medications by psychiatrists at 10 community mental health centers, would you believe this? Only about 1 out of 10, only 9% of the communication actually presenting LAIs focused on the positive aspects. Just think about that for a second. The ratio is so lopsided. I think it should be a fair discussion about benefits and side effects, but to so underplay the benefits, that becomes a problem. And as a result, only about 33%, 1 out of 3, accepted a treatment option that is legitimate and useful to them. And when LAIs were presented in a more positive light with more information, that percentage jumped from 33% to 96%. And that is, of course, a big, big, big change. So communication matters, reflective listening matters, and to do it in such a way that we are both humble and show humility and appreciate where patients are coming from may be the key to success. What do you think, Dooney?
No, I completely agree. I think communication is extremely important, and how we communicate impacts our ability to provide good treatment and build alliance, which has an impact on outcomes, for instance, such as treatment adherence. Rakesh, what do you think are some of the factors that influence treatment adherence?
Tuni, there are actually a number of them, and I like that, because when there are a number of factors, then if one particular issue seems too hard to solve, I can turn to many others. So let me run some of those by you. And let's never forget that race and ethnicity and gender and sexual orientation and socioeconomic status all can have an impact on any and all of these factors. So the illness is impacted by, well, the caregivers and social support, obviously by the patient's own belief system, the kind of treatment they received, the treatment setting, that can matter a lot. Voluntary, involuntary, outpatient, not outpatient, with their peers or completely different people. And then finally, this is why we're here today, clinician factors. All of these traits and factors can really profoundly, either positively or negatively impact treatment adherence to medications in schizophrenia.
Schizophrenia or any other mental illness is a challenge. Combined with the experience that you endure as being a person of color, it adds a whole new dynamic. And so in these next few audio clips, we hear from more racially and ethnically diverse clients who have been diagnosed with schizophrenia, and listen to them talk about cultural sensitivity in the disease, in the management of their disease.
I've been in the mental health system since I was 12 years old, and being biracial, African American and Hispanic Mexican descent, I have never ever encountered any healthcare provider be culturally sensitive or anything of that nature towards me. I've been in and out of hospitals about 20 times. I'm still in the mental health system, and I've never had any healthcare provider be culturally sensitive. I've actually discussed like having paranoia due to the stuff that goes on in the news having to do with people of color being hurt or killed and how it makes me feel, and they seem to kind of brush it off as pure paranoia. And that is probably one of the scariest things that I encounter with a physician or provider if they do that.
Speaking specifically as a person of color, I do not believe that my healthcare providers consider cultural sensitivity discussing treatment options and long-term management of my illness. My current healthcare provider did, in fact, suggest that calling the police if I was not compliant with going to the hospital, and I felt that that was insensitive considering the current issues with people of color and the police.
I would say the top thing would be, having been at my sickest, my most ill with schizophrenia, I have had the police, law enforcement calls on me most times for the littlest reasons, like just being in an episode or even not taking my medication. I've had an outpatient clinic call on me to take me to the hospital, and they call law enforcement to transport me and whatnot, and it's very, very, very scary for me as someone who has mental illness, severe mental illness, and someone who is a person of color to interact with law enforcement. And that actually, going forward, I will try my very, very best not to end up in any situation where I need to be in the hospital or the situation where I would have to have the police called on me.
Gosh, Duni.
That I heard. I know. What was common through all of those three clips was the experiences and the fear and anxiety attached to engaging with law enforcement, and what that can have in terms of engaging in treatment and engaging with providers. And I think it also speaks to how things that are happening in society has an impact on each of us individually. And I think that this just speaks to what that impact looks like with individuals diagnosed with schizophrenia.
No man or woman or person is an island. That's what I'm hearing you say. And that's what these patients are telling us. Yeah, there are factors, societal, personal, family, that really do impact things. And it was really, frankly, shocking. And I needed that shock, to be quite truthful, as to how diverse the impact is when a provider, for whatever reason, lacks cultural sensitivity. Using the threat of police as a means to get patients to comply with treatment, that's, of course, a hard, bitter pill for you and I as healthcare professionals to swallow. So, why don't we do this, Dooney? Let's provide our audience with some guidance. What are some strategies to improve cultural competence?
Yeah, so one tool that I really like is the cultural formulation interview. It is in the DSM-5. It's a fantastic tool that we have trained providers and community and mental health agents here in Washington State on how to use this with clients and with family members. And it was developed by Roberto Luis Fernandez up in New York, who provides fantastic training about this tool. And so the nice thing about this tool is that there are two versions of the CFI. There's a patient version and there's an informant version. And the one for patients it has 16 open-ended questions. And if you're not able to get that information directly from patients, you can use the informant version. And specifically what I like about it and the feedback that I get from families and clients is, you've asked me the questions. Thank you for asking me the questions. And it's really known for building rapport, which has an impact on engagement. And so some of the questions are really focused into these 4 different domains, which is the definition of building that individual family unit's definition for culture, because that can mean so many different things. But the nice takeaways from it is that it builds rapport. It provides less stress in a potentially already stressful environment. But then providers are able to use that to inform the care that they have and really base it on families and clients' perspective of their culture and things that have worked for them. And so it's a really nice tool to use.
I'm so glad you're endorsing it. I too, based on my own learnings and my own trainings, am a profoundly strong supporter of the DSM-5's recommendation on cultural formulation interview. And the way you described this is very optimistic and forward-thinking and a hopeful message. Should I not know a particular culture, what you are literally giving me is a roadmap on how I can not only better understand aspects of it that pertain to my patients, but there is a process by which I can sensitively and appropriately understand the patient's own perspective and therefore be an optimum clinician. So I'm very glad you talked about it. I'll take this opportunity, Dooney, to highlight one more thing for our colleagues, and that is motivational interviewing. I have been undeniably a strong proponent of it for decades because there are strategies from the world of motivational interviewing that could be used even in the context of our joint goal, which is improving our treatment outcomes with schizophrenia in patients of any and all kinds of racial background. So there's 4 steps in it, as we all know. Collaboration, which, as you can see, has elements of the cultural formulation brought into it. Acceptance, helping people better accept not just the plight of their disorder, because psychiatric disorders are genuine disorders of suffering, but acceptance of the modalities we will use in order to get out of that situation. Compassion. Compassion. Knowledge is an important aspect of being a great clinician, but compassion that is genuinely felt by the patient because it's genuinely offered by a clinician often works as well as the most powerful medication I can possibly offer. And of course, the 4th step is avocation. And when all of these 4 things, critical elements of the motivational interviewing, are brought into the picture, our task becomes just a little bit easier. And I would like for you to, in a second, reflect on that. But I would again suggest, as I'm showing you here in the slide, that using these motivational interviewing techniques, is something to be used as often as we can with as many patients as we can. And the 5 or 6 patients who have testified already, it makes me worry that a cultural formulation perhaps wasn't utilized in an ideal fashion, and motivational interviewing techniques were perhaps not used. Maybe they were exposed to the model that used to be in vogue decades ago, Dooney, which was much more the patriarchal model. I am the clinician, I'll tell you what to do. And of course, that doesn't work very well in any context. So may I have you reflect a little bit on your thoughts regarding motivational interviewing?
No, I think that it is a fantastic tool. I think it's also a tool or a strategy that is, in terms of obtaining the training for it, is readily available. And it's definitely something that can be used combined with other things. And I think that's the nice thing about motivational interviewing. So for instance, you could absolutely use the CFI along with motivational interviewing. And so I think that that's one of the beauties of motivational interviewing, especially because it is something that has a lot of evidence behind it.
Yes, so very true. These are not models in competition with each other. They're actually synergistic with each other.
So Rakesh, there are ideal communication strategies that can be used specifically for discussing the use of long-acting injectables. Can you talk about those a little bit more?
I'd be happy to. This has been a passion for me for some years, so always happy to talk about my own pet projects, and particularly projects that have measurably improved the outcomes for my patients. And one such approach is called the GAIN approach, G-A-I-N. And I would love to tell you more about it. So G stands for goal setting, A is for action planning, I is for initiate treatment, and N is for nurturing. You got it, motivation. Let me talk a bit about that. Let me add a bit of color to what I just shared. So goal setting really has to do with the patient's goals. Sometimes I have to guide them into what goals to look for, but essentially all human beings, no matter how psychotic we are, we have certain goals. I need to create a better understanding of what your dear patient, your goals are. And together, collaboratively, we'll do goal setting. After that, we turn our attention to, now that we know what the goals are, what is our action plan? What will I do? What will you do? What will we do together? Often, this is a great place to bring in a conversation about LAIs, because most of the patients I see, Dooney, have really struggled with adherence. They really have. And I, as gently as I know how to, understand their plight. I tell them quite honestly, last time I was 100% compliant with a course of antibiotic therapy that lasted just, say, 2 weeks was never. And here I am asking them to be adherent to their medications for the next 20 plus years. I understand their plight. And that's part of the action planning, is to create this rapport of humanism, of the belief system that we are in this together. Once a patient fully understands the advantages, disadvantages of an LAI, then we initiate therapy, never minimizing their concerns. If they're afraid about pain, I talk about that. If they're afraid about, will I have to admit to people that I'm taking LAIs and I don't want to? No, you don't have to. This will be something you and me will be talking about. And then finally, nurturing motivation. Just like raising a child, it's not enough to just have a great childbirth. It's also important to raise the child. The same way I look at continuing treatment with an LAI as a process that requires nurturing. I commend people, I congratulate people for doing the right thing by themselves. I tell them you are brave, you're courageous, you're smart, because they are. And then I use other motivational methods to make sure that I am fully behind them. So Dooney, I do think the GAIN approach can be applied to the vast majority of patients on LAIs, and it has proven itself to be very effective.
It sounds really good. It sounds like it's kind of combining things that we have addressed a little bit earlier in terms of shared decision making and motivational interviewing kind of combined into one, making sure both of those things are important, especially as it pertains to LAIs. So as we were talking about, communication is extremely important, and providers are aware of these additional strategies that they can use with patients of color to establish trust and engage them in treatment planning. In the absence of cultural sensitivity and awareness of healthcare disparities and bias, patients can easily lose hope. And so in this next clip, the patient that is really talking to the need for hope and the importance of hope, especially as they matriculate through treatment.
Myself personally, I have most definitely endured many negative experiences when seeking mental health care. I don't think anyone has had an overall positive experience seeking mental health care. And these experiences, they make it so that you feel like there's no hope. And when you have no hope, you have no desire to move forward, you have no desire to feel like there's a future for you. And so most definitely it has affected and impacted the trajectory of my illness.
This is exactly right, right? Like pathways to care, pathways through care, even when it's receiving the appropriate services, is combined with both positive and negative experiences. And for racially and ethnically diverse groups, they have more negative experiences. And it's important for us to understand, one, what those experiences are so that we can actively combat those experiences once they get to the appropriate services. But to also make sure that they don't have these negative experiences when seeking services. I always think about it in terms of, I don't like it when I receive negative experiences when I'm getting fast food. So for something more important than fast food, such as mental health services, it's extremely important that these positive experiences outweigh the negative experiences so people remain engaged and they don't lose hope.
So well said. I mean, that's beautifully said. It was hard to listen to the patient, but very easy to listen to your highly positive way of approaching this challenge, which is let's give our patients collectively, by better understanding their specific challenges, whatever they might be, and to meet them using the models that we have discussed to make sure, as you said, the positive experiences outrank negative experiences. Duni, I'm not about to forget that, I don't think, ever. So thank you so much for that. So we've had a great discussion on addressing racial disparities in patients with schizophrenia. Duni, I would like to invite you to make a few concluding comments.
Yeah, so we have talked about so many different things throughout today's presentation, and I think that the key takeaways are that, one, racial and ethnic disparities exist from diagnoses all the way up into the management and treatment of mental illnesses such as schizophrenia. Second part of that is we see these disparities through mental health services, through the use, through stigma, through bias, conscious or unconscious bias from providers. And then lastly, we provide these different tools that providers are able to use that are really rooted in motivational interviewing, improving communication, and providing cultural sensitivity. And so these tools should and absolutely be used in order to provide more equitable services for racially and ethnically diverse groups.
Entirely agreed with all 3 points. Wonderfully said. So spot on. And we are a very diverse society. Your very first slide reminded us quite clearly and eloquently that we are a melting pot. Yet in this melting pot, there are things to be aware of and to address specific issues, as you just highlighted for us. So thank you so much for that. And clearly there's a lot of work to be done. And we hope, dear colleagues, that this discussion has not only given you, our audience, some things to think about, but also some things to do. We would be sad if all this conversation does, it provokes thought. It should do that. It should also provoke action. And with that in mind, let's wrap up with our SMART goals, S-M-A-R-T, SMART goals. That is actions that we hope you can use in your practice. And these SMART goals, of course, are Our goals have to be specific. They have to be measurable. They have to be attainable. They have to be relevant to the problem we're trying to address, and they have to be timely. When we apply these SMART goals and we acknowledge things such as race and ethnicity can influence the diagnosis or management of schizophrenia, we are aware that incorporating such culturally sensitive strategies to engage individuals in shared decision-making may lead to enhancement and outcomes all the way around. And the tools we talked about, CFI, the GAIN model, the MI, motivational interviewing, all of these successfully educate, empower, and engage our patients with schizophrenia, no matter what treatment they might be on, either oral medications or LAIs. Colleagues, this has been the final episode of a three-part CMEO Snack series on overcoming barriers to the use of long-acting injectables in schizophrenia management, because every patient deserves recovery. Please join us for additional episodes in this series as our colleagues address the impact of comorbidities on morbidity and mortality in schizophrenia, as well as the role of long-acting injectables in getting our patients to remission and recovery. Now, to collect your credit for today's activity, you can click on the link to complete the evaluation. You will be able to print your certificate from the platform. Dooney, pleasure to be with you. And I would again like to thank you for joining me today for such an important discussion, a scholarly discussion, but also a discussion we had from our very heart. And thank you for your contributions in addressing racial disparities in patients with severe mental illnesses.
Thank you for having me. I think that what we have spoken about today is incredibly important, and I really hope that, like you said, it gives you food for thought.
It does. It definitely does. And again, I would like to thank you, dear colleagues, our audience, for participating and for providing the very best care to your patients. Take good care now. Bye-bye.